have a new staffing model that I'm going to introduce to you all that Confluent has introduced to us and that we need to abide by. This staffing model is certainly something new for all of us. We're in the discovery and learning phase, so kind of bear with us as we go through this. I'm going to give you the details of the staffing model as it applies to what a new term that was introduced to us, that is capacity, and that is capacity of operations. Keep in mind that word behind the back of your head because it is a whole new term that we will be dealing with today and through the rest of the year and in the future, I'm sure. But the staffing model is based on three concepts. One is patient visits, full-time equivalents, and scheduled hours of operation. So those are the three major terms, and I'll try and explain to you exactly how those fit into our staffing model in a second. You all received a copy of what is titled the staffing model, and it's up right now on the screen. I've set it this way so that we can look at this, how Confluent looks at our operations, and that is per week, okay? We're gonna go through this on a per week basis, and then we'll come back and talk about daily basis, all right? Kind of stay with me. If there's any questions afterwards, let me know, but let's try and go through this strategically, and then we'll come back to it if there's questions. So having said that, let's talk about if we're going to plan for the following week, we'd be talking about this on a Friday. Let's imagine that today's Friday, okay? And we're talking about the coming week. We're going to project, and I'm going to use as an example, that we're going to have 148 visits. And I'm using that number because that's the highest that was seen by East last week, I believe, or pretty close. I think it was 145. So let's use the example of 148. Keep that number in your head. The second thing you got to look at is total clinician hours scheduled for the week. That is PTs and PTAs. So at this example, we're using 95 total hours for the week. So now, total clinician hours is your 95. You're gonna divide by 40 hours because that's 40 hours in a week, which will give you your full-time equivalents. So if we use this example, 95 divided by your 40 hours, you'd be working at a 2.375 FTEs. You'd be using 2.375 full-time equivalents to see those 95 visits in a week. So on number 4, your total visits on top, the 148, you divide by the FTEs that you just got summarized by dividing 95 by 40. So 148 divided by 2.375 FTEs gives you 62.9 visits, rounded up to 63 visits per week. Are we together still here? Okay. So your visits per week you've determined now are 63 visits for the week. So based on the FTEs, so you divide that by 5 days, it's going to leave you at 12.6 visits per FTE per day. So let's talk about that a little bit. So is that 12.6 visits per shift? And no, we're talking an 8-hour day. So that is the basis of this, is that we're talking about an 8-hour day, okay? All right, gets a little bit complicated here because with a week, you're determining, and projecting how many staff members you want to have for that week based on 148 visits for the week. Okay? If you see 12.6 visits per FTE per day, you're going to have, say, 6 patients in the morning and 7 in the afternoon, or vice versa. Or in the case of a couple of our therapists, mainly Chole and Amanda, that work 3/4 time, they'll be seeing 12.6 visits during that time. So it's a little different than a full FTE of 40 hours. Have I lost anybody yet? Does it make sense? Okay. Now, capacity, that is staffing model that Confluent wants us to look at from now on. It gives us an ability to project how many professional hours we can schedule and still be within budget based on your visits for the week. So now I'm going to introduce capacity. According to Confluent and how they operate, and this is for COVID-19 right now, if you have 11 visits per FTE per day for each clinician, if you had them all show up, you'd end up with 55 visits for the week. They're saying that if you see 11 or less per day, you should be using 0 technicians, 0 technician hours. Now, if you would say, if you see 14 visits per FTE per day, you'd end up with 70 visits per week, and you would necessitate 1 technician for those 14 visits per FTE per day. So if you had 14 visits, say, on Amanda and 14 visits on Rudy, we would need 2 techs. Correct? All right, but no more than that. If you had 16 visits per FTE per day, you'd end up with 80 visits per week. And that, they say, would then have to have 1 tech per PT. How is that different from what I just mentioned with 14 on Amanda and 14 on me? Well, that's because they're talking about 1 PT. If 1 PT saw 16 visits, they're saying you would schedule a full-time tech for 8 hours with that PT. Are you more confused, or does it make sense? It takes practice, and it makes sense once you practice. Did someone have a question? I heard somebody come on. No. That tells me 1 or 2 things. 1, you're completely confused, or 2, you really don't want to ask a question that you don't feel comfortable with. Or does it make total sense to you?
I do have a question. Can you hear me?
Yes, sir.
Okay, so I do understand the model and the math behind it. So my concern now is, given that we're reducing the number of techs, it kind of falls in line with the number of visits we're kind of have right now. When are they finding time to document?
That is called point of service documentation, and we are not used to that. We hardly even have time to do it at the end of the day. They don't talk about documentation time. They figured documentation time into the FTE formula, according to David Browder, my mentor for this region. Like I said, this is a new concept, or 2 new concepts really, and we're gonna work towards it, okay? We're gonna gradually go into this new concepts. You don't have to go back and do this tomorrow or the next day, but try and practice with it so you get comfortable with it, so that when we do implement it completely, we are in line with Confluent. But right now, I know that we use text to help us a lot. We use text quite a bit, and that's okay. In fact, what David told me during this talk with Sylvia and I, he said, I'm not telling you not to use text. If you feel like you need them, it's up to you, but this is what we expect. So really, it was to me, a double-edged sword. It's saying you can use text if you want, but it's going to affect your productivity according to what we see and your capacity. So we have to really keep in mind, and this is generally speaking, he said, you should never have more tech hours scheduled than professional hours. It should be about the same or less tech hours than professional hours. That is a guideline. For instance, if I had 95 clinician hours scheduled for that week and 140 hours of PT techs, that would be way over, according to the formula and to how they operate. You might say, but how do we get all the visits done? And I'm so busy all the time already. Well, one concept David brought is, if you ask a PT or a PTA, how busy are you? We'll always say we're very busy because we think of immediately the days that we were busy, but not the ones that we weren't busy. And we'll always use the busy days as a barometer for how busy we are. So, you know, these two concepts are very new. What we can go further into this is per week. We can determine per day by using the same formula. Can you take me up a little bit, Mando? But instead of, say, for example, let's use the example we worked on this morning. Let's say we had 35 visits for the day at one clinic, whether it's East, West, or Horizon Valley. I wish it was West, but it's not. So say we had 35 visits for the day. We're going to forget about the week, okay? We're talking about an 8-hour day. So the example is we would put 35 visits right there under number 1. And I would have, according to my schedule, 21.5 hours, clinical hours scheduled. Okay? Follow me? For that day. And it's a full day, 8-hour day. So the total clinician hours, 21.5, I would divide by 8 hours, not the 40, which would give me an FTE for that day. And that turns out to be, by the way, 21.5 divided by 8 gives us 2.69 FTEs. What it's telling me is that I need 2.69 FTEs in order to see those 21.5 visits. Okay, so now you take your total visits, 35, you divide that by your 2.69 FTEs, and that would leave you at 13 visits per FTE per day. Now, 13 visits under capacity is more than the 11 per day per clinician. So you would need a technician, correct? Okay, because 11 and under would be 0 techs. That's how you determine it. Does that make sense on a daily basis?
It does.
Because if you're seeing 13 visits, if you were seeing 13 visits a day continuously, would that be a number that would be doable?
13 per day, definitely, yes.
Yes, because sometimes we see 13 or 15 in half a day. But it just gives us a guideline. If you have 15 visits in the morning, then you're going to jump to between 14 and 16 on capacity. And so you need maybe a tech and a half. And that's something that you as CDs and me as a CD need to look at and make sure that we are functioning at what this would be perfection. And we know that some days are busier and some days are lower. So any questions on that? Because with this information and knowing that we can go into the week and break it down to a per day for capacity, it makes scheduling, it becomes critical now. The front office has to make sure that the scheduling is appropriate for the visits and the number of, or the staffing model. So if the front office schedule is not meeting what we need to do, it's going to throw everything off. So it becomes very critical that the front office understands this very well as well. So, any questions to this point?
Yes, Rudy, we do have one question. And the question is, how would that work on Friday with only half-day clinical hours?
You still are getting paid 8 hours for a Friday, where they look at the day as an 8-hour day. Whether we're open 2 hours, 4 hours, or 10 hours, it's looked as an 8-hour day. So you still figure it out according to an 8-hour day. Make sense? Okay.
Any more questions?
For instance, and I'll give you another example before I go away. For the West Side, yesterday, we had 8 visits. Sorry, we had 14 visits scheduled because we didn't see anybody in the afternoon. So 14, you're gonna use the 14 visits. Let me go up a little bit here, Mondo. Oh, there you have it. 14 visits divided by your clinician hours, and we had 8 hours scheduled of clinician hours. I had 5, I believe, and Lynn had 3. So 8 divided by 8 gave me a 1. That's very simple. 8 divided by 8 is 1 FTE, right? So anyway, I took my visits of 14 divided by 1. It gave me 14 visits per FTE. However, I had 8 hours of technician scheduled. So was I overstaffed? Most definitely. If I had 14 visits and I had Lynn, I shouldn't have had a tech at all according to the formula.
But the formula says that you should have had one.
Pardon me?
The formula said that you should have had one.
One tech.
Technician.
Right. So, you know, it looks like I shouldn't have, but actually the formula gives me under capacity, and that's a very good pickup, Chole. If you go down under capacity, if it's 14, I can use 1 tech.
But you said it was a combined 14 visits between you and Lynn?
Mm-hmm.
Well, then that would, so it was 8 and 8?
It was 7 and 7.
I mean, see, I can't even have it right now. So then it wouldn't fall, would it? Because it's talking per full-time employee, not 2?
Yeah, but remember that I'm not working 8 and he's not working 8.
Oh, gotcha now. Okay.
Okay. That's why when you divide the visits by the FTE, by the hours, it gives you the FTE you should have, and that is 1 FTE. And we worked 8 hours between both of us.
Now I got it.
Becomes a little confusing, but if you got that, Isaac, yay, you got it. That's as simple as it gets. But I'm gonna ask you guys, not right now, but when we finish this talk today and at the end, I'd like for the CDs and possibly the OCs to stay afterwards and just practice this for about do one per week and one per day example, and then send it to me so I can review them and let you know if it's correct or not, or where we need to go. Yes. So please send it to me. Stay after the meeting for just 15 minutes. Do one example of each and send it to me, and I will get back to you guys by the following day. Yes, thank you. I believe if there's no more questions on chat or anything, Mando.
No more questions on chat.
All right. I'm done with my part.
Okay, so for the next part of the presentation, Sylvia Reyes is going to present the finance and administration.
Okay, I'm here to report difficult numbers. It is, as it has been mentioned, EPPTS is facing hard financial conditions, and it has been due to a significant decrease in volume. In the month of April, 990 visits as a whole. And in May, it went up to 1,100 visits. So we did implement phase one, cut in expenses by reducing employee hours based on volume that we were used to. At that time, Confluent had not presented the staffing model to us. Unfortunately, this phase one is not making the break-even point for the company. So I'm going to elaborate a little bit on the break-even point. So it is based on the production level that we saw in April and May. Total revenue, estimated or projected, is not equal, should be equal to the expenses. And with the current expenses that we incur in the month of April and May, we should have been, or we should have seen 1,250 visits on the 2 months, April and May. And as I mentioned, April was only 990, May 1,100 visits. So with that, we had to go to a phase two of reduction in expenses. Now, the key elements to calculate the break-even point are fixed costs, of course, the visits, the revenue, and variable costs. Those elements are used in the formula. Since April and May visits were significantly under or lower, that means that our fixed costs were higher than the projected revenue that we are going to receive in the month of June and July. So we didn't see that effect or that financial constraint in April and nor in May, because we were still getting payments from mainly February and March. What we are going to feel it is right now in the month of June and July, because that's revenue business that we're seeing in April and May. So again, an explanation on fixed costs are expenses that remain the same and are not related to the fluctuations in productivities, and those are such as rent. We have to pay rent regardless if we are open for 990 visits or if we were open for 1,800, which we used to be in the 2,000 visits per month. And right now we are only operating, in April we were operating less than 50%. So it's rent, of course, salaries, and health insurance benefits. So health insurance is the main one in our benefits. PTO, sick time, of course, those are benefits. Therefore, our break, I had to recalculate a new break-even point base so that we can continue to keep EPPTS afloat because we are here to continue to have our doors open for all of us to have a job with the company. No layoffs. We are only reducing hours at this point on phase 2. And we have to cut additional $10,000 per month. And that's in phase 2. So for the new break-even point in phase 2, with a 10,000 reduction in expenses, we have to see at least a minimum of 1,164 visits per month in order for EPPTS to be able to meet expenses. Now, phase 2, of course, was an additional layer on reduction in hours from a clinical standpoint, as well as office and administrative personnel. We have a freeze on expenses. Marketing and IT budgets were reviewed and we have them on freeze. All unnecessary expenses right now are completely on freeze. Invoices that are getting paid on accrual basis, we are holding them until they are due, the time that they are due. And of course, we're getting phone calls from vendors, calling regarding the status because they were used to receiving those payments on a more timely manner. So that's phase 2. In addition to phase 2, what from the beginning, back in March, we had a meeting. We are taking advantage of the federal and state assistance programs under the CARES Act from the employer standpoint, as well as from at the employee level. From the employer standpoint, we requested, we defer our rent. So for the 2 clinics that we are not paying rent right now is West and Horizon Valley clinics. Eventually, we made a payment arrangement with the landlords. We're gonna have to catch up for the remaining of the year. We also apply for Health and Human Services for the Medicare Advanced Stimulus Pay. We were eligible for the first time round. We already received those funds. We applied for the second round, and as of today, we have not received the second stimulus. So I'm gonna have to follow up. I need to follow up on the second round. At the employee level, again, no layoffs. One concept was we share the pain for a future gain. So Confluence sent a message to let's avoid layoffs. We went into the reduction in hours. I apply on the employer for the employees on the Texas Workforce Share Work Program. At this point, most of the employees have qualified for, in addition to the reduction in hours funds, they are getting almost, all the employees are getting a full, that's $600 in the state of Texas for the pandemic unemployment assistance. So we were concerned about EPPTS employees. We took advantage of that program. We are happy that most of you are getting that pandemic unemployment assistance. Those funds are every week are coming to you all. Now, what is important for me to clarify, we have 2 programs for you all right now. One is the TWC Share Work Program, where you can get up to 90% of pay, from 80 to 90% on your full-time status or your average hours, and this includes part-timers. So that is program 1. Program 2 is the Pandemic Unemployment Assistance Program. Those are $600 only in the state of Texas. Every state is different. This program was approved for 13 weeks, it will come to an end on July 3rd. Last week, it was extended. So now there is going to be an extended to another 13 weeks, and that will come to an end the end of September. I don't know, we don't know. I don't know if, the president will continue to extend it. The TWC Share Work Program has been approved for EPPTS through next year, March 31st, 2021. That is the reduction in hours. The pandemic unemployment assistance is now being on a 13-week period. The first 13 week is going to come to an end, has been extended, so now is the end of September. So at this point, last time I stressed to you all that to manage your personal finances as best as you can at a personal level. The pandemic, COVID-19 we are in an unknown territory. Save those funds additional funds that you are receiving right now, as much money as you can save right now. Because we don't know what's going to happen. So right now, let's take advantage of that program, and hopefully it can be continued to be extended. The recovery process will be a long term, and unfortunately, right now we are behind 2 months, the month of April and May, on that we did not meet the break-even point. Therefore, we need your assistance right now, especially during the period of June through August. This is the first week that we had a city meeting. We reported a new increased level of visits and increase in referrals. We don't know what the cancellation and no-show is going to be based on now, this new increase, but only 1 week is not enough for me to say, oh, now we're going to have, more visits. Yes, we are going to be able to meet the break-even point. No, I need history. I need at least 4 weeks to say, now it's a pattern. We have 4 continuous weeks that we are operating now at this new level increase. Then we can read, we can project better. So with that in mind, what we are asking is, right now we will not be laying off. We will continue a reduction of hours as EPPTS volume increases. EPPTS ship needs to sell as financially stretched as possible. I know it's hard because we are learning with Confluent new model. We are doing the transition in different departments. We are having COVID-19 compliance, and counting human resources is changing our systems completely due to COVID-19, operating different. And then we need to continue to operate our normal duties. So we need to be efficient as much as we can. Hopefully our volume continues to increase in the next months, but in the meantime, we will continue to monitor the visits and the finances as very closely, and we will keep you informed if there will need to be any other changes to take place, any other changes. We hope that that will not be the case, but again, we are in an unknown territory right now. We will also analyze the break-even point once the month of August is closed, and we will reevaluate the financial condition of EPPTS, since at that point we're going to have to start paying the deferrals and other expenses that we are holding. and we will reconsider the reinstatement of reduction in expenses until we close the month of August. Again, EPPTS remains committed to adapting to these financial challenges and to position the company for financial solvency. So we are in June, we have to June through December to make it up so we can at least are able to break even and have EPPTS in a stronger financial position, because now we need to prepare for the beginning of the year, high deductibles, co-pays, and the whole thing. So that's my section. Does anybody has any questions?
Anybody?
Just maybe one comment, Sylvia, that the tough stretch right now is all summer from June all the way to the end of August. We hope that, and at the end of every month, we're going to be just looking at it with such precision, how the month ends, how we go into the next one. So it's just a tight summer.
And I have one comment to make too, based off of a conversation that Chole and Sylvia and I had, is that our high flu season starts in November in El Paso, November and December, January, February. So we have between now and October to really ramp up and try and get as much profit as possible. Because if this flu season comes on because of the fear out there of COVID-19, could be confused by patients and might drop again our census or our capacity during those months. So now is the time to buckle up and try and get all these visits as much as we can.
Okay, any questions for Sylvia? Okay, if not, I encourage you to, if you don't want to send anything now, I encourage you to email Sylvia or communicate with Sylvia. I'm sure she'll make herself available to answer any questions or concerns that you may have. So we're going to move on in our presentation over to the marketing department, and Margot will be taking care of this portion.
Thanks, Armando. Can you please put my agenda up? So that way, because it's different than the one on the, thank you.
And let me grab it. It's not the scripting, it's the agenda.
Just the agenda for now, please.
Okay, yes. I don't think I was ready for that. Give me one quick second.
That's okay. Thanks. Can you click on the other one so it, does it take off that there and then down? There you go. Thank you. So I'm going to touch briefly on each point. So it's a little different than the original agenda, but wanted to give everybody a brief update on the COVID status here in El Paso. I don't know if all of you are following, but today there was reported 2 new deaths this morning in El Paso, which brings our total to 93 deaths, 59 new cases, and a total of 3,512 cases. 95 hospitalized, 61 in ICU, and 29 on ventilators. So just a little highlight of the state of the city in regards to the COVID-19 cases. Regarding the practices, currently the processes and patient census within our providers' offices, we're still not seeing PCPs working at even a 50% capacity. Some of the, as we know, the surgeries have started back, but they are still also experiencing cancellations for surgeries because still the fear of the spread of the virus. And just an FYI, one of our geriatric physicians, Dr. Monroy, he has still been closed for practice. I reached out to them last week and again yesterday, and they continue to be closed because patients aren't wanting to come in. Their telemedicine is also sparse because a lot of their geriatric population patients don't do technology or prefer not to have visit at this time, whether it's a phone call either. So again, PCPs are working at less than 50% capacity, which then puts a wrench into their referrals to specialists, but hoping to pick up direct referrals from PCPs to us in the interim. So regarding, the other thing is to please note that a lot of the offices are still working with minimal staff, apparent, and the hospitals as well. People that are out on pandemic pay, I think, are kind of carrying it out as long as they possibly can. So that is also some of the surgical employees that kind of is dependent on the surgery scheduling as well. So I am keeping up with my contacts in the hospital communities across the board regarding surgery. So I will continue to keep you all posted on that. And to piggyback on the referrals that we have right now are going up, but again, that's going to be fluctuating, I'm sure, over the course of the next month or so. So really it's imperative across the board to have all hands on deck and really work together, especially between the front office and the PTs as we get into the scripting for trying to retain and the retention of the patients we have currently in episode of care, and also to ensure that we bring any new referrals in and to get them in our care and continue with that care, and hopefully in person more so than telemedicine. So current state of marketing and EPPTS Confluent Health, as Sylvia mentioned, all expenses, there's no expenses out for marketing. So therefore the blitzes, the luncheons, and the wow factors will be on hold. And like she said, we have a recovery process financially, and that's going to probably take us well into 2021. So I will keep you all posted on how the marketing is going to go, but the visits will continue, and making sure that our collateral, all our information is out there, and working closely with the office staff, mid-level providers, and physicians to continue to bring in new referrals, and I will continue on that. Just so you all know, on the phase 2 reduction, my hours are at 25 right now. So I'm working also on my Confluent Marketing Academy. I've been meeting with them now the last 2 weeks, various meetings. And so I have also information and some courses that I'm taking for Confluent. So just to let you all know, I'm available Monday through Thursday, and anytime really you all can reach out to me on my cell. The marketing plan for Q3 and Q4 and into 2021 right now is again, communication with the physicians, mid-level providers, MAs, and office administrators is what I'm working on and continue to work on. I'm doing the in-person visits. Most offices I can go in, but there's still a few exceptions. So I am working with whoever is the greeter at that particular physician's office. Through this time, I think it's really important, and I believe as we all merge more into Confluent, we're going to be seeing that we are going to be diving more and more, obviously, into their culture, and the professionals, the PTs, will be much more engaged in the physician component and doing more PR levels and connecting and partnering closer in patient care with those physicians. So I ask at this time, as we get further into our scripting, that'll be next, that if the front office staff is not closing the deal, so to speak, with a patient that's a new referral, there's going to be various ways that I'm asking everyone to implement in their scripting, as far as instead of taking no for an answer, to try with more information, to making it conversational with the patient to come into their initial eval, or to continue with their episode of care if we think they're going to be falling off. And I think that's crucial, because I think perhaps maybe a PT can take over and give a more in-depth clinical value to why they need to come in and why they're their physician is referring them as well. So we'll be talking about that a little more. But it's really important to keep in contact, especially with our current patients that have fallen off their episode of care. You know, right now it's imperative to continue to retain those relationships. We just can't say, oh, they're not coming in. We have to reach out to them, just checking on them, just doing a wellness check to say, how are you doing? You know, we just want to make sure we're preparing for your next visit, whatever it may be. But I think engaging in relationship building is not just a marketing duty. It's for all of us to do that on the front end and the back end. And people remember those relationships that we're building with them and the outreach that we have. There's one lady, Mrs. Anderson at the West Side, that I had to help with her car, you know, just to see, I don't think anybody had checked on her. So I called her just to say hello. I know her memory's not the best, so she may not remember me calling, but we had a great chat. So those are the things that I'm saying, you know, people that, you know, I know our open gym members are back, but, you know, during this time, reach out to them. If you see somebody that's not coming back, that you haven't seen in a while, just reach out to them to say hello. Or, you know, or any of our aging patients that you made a connection with that may not be currently with us, but just do a wellness check, because we never know, you know, what family members they have here locally. So it's always nice to follow up with somebody. And we've been keeping up to date with the website and social media. Just so you all know, I'm working closely with compliance with Chola, Amanda, and Lydia to make sure that the updates are made accordingly. So that way the public and providers have information at their fingertips as to what we're doing. And I think we're doing a great job. And just so you all know, I don't know if I mentioned this last time we met, but the Confluent people did say that of all the providers all the companies they've partnered with, that our website was excellent. So I think we shall take great pride in that. That was a big effort to put together. Also, I want to extend, we need to really build a bigger presence on our social media and obviously the website. And I know we have the cards that document that, and we're telling the patients, but I think we need to educate them a little more and entice them to grow our social media and to invite them to be part of that. So if you all could do that when you're reviewing those cards with them, I'd appreciate it. And I've also asked during this time that the owners do a social media video, which I think is real important to connect to the public. And Rudy has done that. So if you all go to our website, you'll view that. And as we go along, I'd like to make some more. And on those lines, I want to make sure we continue to connect our PT and professionals, PTAs, with the public. And I know we did that last year with the Horizon social media, but I want to continue that and do some more organic taping without a host. And it would just be you, the PTs, professionals, to speak on a topic, little 3 short-minute video, and I'm going to employ Armando to help me with that. But I think it's important to stay top of mind and have that presence on social media to connect with our viewers. So that's going to be coming within the next few months and going into 2021. So the next thing I want to talk about is the scripting. If you could please put that up, Armando. Thank you. So I was asked to develop scripting because, again, going back to what I was talking about earlier, it's very important that we engage in conversation and build those relationships with patients from the initial impression, from the time you pick up the phone or you're calling the patient. And there's 2 different types of scenarios that we're dealing with right now, and we have been, is the new referral patient, and then the existing patients that are declining to follow through on their episode of care. So there, in the engagement of the scenarios, the importance of following for a new referral is to impart to them the importance of why they're coming in, why the physician has referred them to us, and it based on their condition. So this is just scripting guidelines. I know everybody's articulation is different, but you all can can read this and see how to express to this patient the importance of coming in for PT. It's engaging in conversation. It's not, okay, Mrs. Smith, call me when you can, when you think you're ready. That's the wrong conversation to have. It's to make sure we get them on our books, scheduled in for their either initial evaluation or get them in for further episode of care appointments. That's the important thing. We need to have that business on our books, and we need to make sure that we are nurturing each of these appointments and making sure we're following up with them as we're approaching their appointments. If you can text them, if you can email, plus a phone call, I think that's key to retaining this business or getting the initial visit. So engaging in conversation, again, is the most important thing, relationship building for both new and existing patients. So I'll give you an example here, the new referrals who are declining PT services. Mrs. Smith, your physician, Dr. Alas, has referred you to our services due to your appointment with him regarding your whatever diagnosis is, your hip, your problem with balance, whatever it may be. We would like to assist with your therapy to ensure your health and wellness and to get back to feeling better and get you back to your daily routine. Whatever it is, whatever verbiage you all are comfortable with. But again, it's engaging in why it's important for them to come. They went to their doctor for their condition. The doctor is now referring them to come get better. And each situation is going to be different case by case. These are just options for you all to engage in conversation. And these will be laminated for you all. Cassie's going to be doing that, and I'll be getting them to each of you soon this week. Also another reason that it's important for physical therapy is, wanting to get them in prior to any surgery. I know that documentation also for medical necessity is a big part of physician's report card, and we need to make, entice them that physical therapy is important, and the patients need to adhere to what the doctor's orders are. Other concerns you all need to address, especially at this time, is the COVID-19 and how to ease those concerns with the patients. And I have some examples below that we are conducting daily screenings that, the patients and the staff are required for the face coverings. And you all know the social distancing and the scheduling accordingly, low numbers, what have you. So all of those, all this information and all these details come into play. So again, it's conversing with the patient, not just simply taking no for an answer. If you all are having a hard time with a new referral or with an existing patient keeping their appointments, please reach out to your PTs. They can help assisting and calling the patient, especially at this time. I think we have time to do that and to engage in that, partnering in patient care. So I think that's crucial to what we need to do to get these patients in, again, new and existing patients. So this information will be, like I said, laminated and given to each of you. And if you have any questions, you can let me know. But these are the two different scenarios that I have right now. If you have any suggestions to add to it, we'd be happy to do that. Okay, and then back to the agenda, Armando, just 2 points of interest regarding our competitors. Sun City Orthopedics, Dr. Sides Group, has opened up a West Side PT service. It's called Performance PT. And so far I know he's employed Patty and a Colton as PTs. And Patty comes from the foundation's PT services that he referred to when they were in his medical office building on the east side, because he's a big investor in foundations and now the new, I believe it's Regent Clinic. So he has set this up. It's slow going because they're still not on all the insurances, but I can assure you if he has a West Side presence, it's probably a matter of time before he has a East Side presence as well. And then Lydia mentioned to me that Water Therapy Services is building their new clinic, and I'm sure it's to replace the current one. It's over in the Horizon area off of East Lake and the Gateway. So very visible to the freeway. And they'll probably, we're assuming they're going to close down the other facility once this is up and operating. That's currently on East Lake. It's a smaller facility. So we'll be watching the progress on that one, but I'm sure it's a bigger footprint than they have now. So we will keep you all posted on that. And I think right now that's all I have. Thank you, Armando.
Okay, and then thank you, Marco, for all the information. I do want to add a quick 30 seconds just to quickly say that Isaac had his telehealth visit yesterday at 4 o'clock, and he reports that it went very, very well. Okay, so the next people that we're going to have coming up are going to be Chola and Amanda that are going to touch on compliance. So at this point, Amanda, I'm going to ask you to unmute.
And Amanda had to step out. She's had to go back with her patient.
Okay, so then
I'll take over for her presentation, and it's short. So from a compliance standpoint, in an effort to assist the finance department with the expenses, we are going to put a freeze on any continuing education throughout the entire summer. I just want to tell you that for 2020, this year, the only person who has their license that will be expiring is mine, and we're on track with that. In 2021, the following are going to be expiring. We have Ruby in May, Eric in June, Stephanie in August, and then Amanda in November. So make sure that the 30 hours that you're going to need to report, you start tapping a little bit at the end of this year, and then in the preceding year in 2021, so that not everybody's taking continuing eds at the same time. That's it for compliance. Oh, and also we wanted to say that if you need to reach out to us as you calculate your continuing eds that you have taken and those that you're projecting to, don't hesitate to reach out to Amanda or myself.
And then we're going to go ahead and move along to the last portion. I'm going to unmute Rudy. There you go. And he has the conclusion for today's meeting.
Well, I know that we have given you lots of information today that we tried to condense as much as we could. I want to recap our meeting today quickly. I understand, that much was said today, and some of it is new, some of it is something that we're building on. And I know that together as a team, we'll be able to pull out of this as many companies throughout the country are doing and will do in the near future. We'll be able to achieve this by understanding the importance of accountability and communication, because those two are very important in meeting any goals that you have. So the importance of accountability is going to be talked about a little bit by Chole. She's going to chime in and share some information on an article provided by TPTA.
So TPTA put out a very good article for those physical therapists that are currently in a leadership position. And one of the things that they recommended, and we are embracing, Rudy and I, as owners of the company, is they reference, please put your best people on the front line. Let them do the day-to-day work that needs to get done, and trust them. You as leaders need to keep your eyes down the road. Do not keep it here. Keep trusting that He placed the best. We just want to tell you that all of you are the best. We have kept you on board. We've done everything to keep our doors open. It has been a tough fight and a very painful one for all of us. But you're the best right now. We chose you. You chose us also. You're in the front line. Stay strong. In the meantime, us leaders are going to keep our eyes down the road. As Rudy mentioned, one of the things that they're recommending that we look at is in your prospective city, pretty much anticipate when the spike is going to go back up. In your traditional flu seasons, and for El Paso, as Rudy had said earlier, it's in November and December. That's when it starts. It spikes in January and February. So what we're doing right now is, as we look all the way down the road to November, and know that our eyes have to go all the way back forward into February. That's where our eyes are right now. We're saying we have to be tight now. We have to make strong profit margin all of September, all of October, so that when November hits and some of the people are afraid to come into therapy, then we're immediately ready to embrace the situation that we're going to embrace at the towards the winter. So remember that Rudy said accountability is real important. Understand your job assignments so well that you can communicate them effectively to each other and to everyone in the organization. I know that all of us are cutting our hours in one way or the other, but we know we can make it. We do believe that. So as we keep our eyes down the road, we trust that you, the best of the best, are holding the fort on a day-to-day basis, and that's what's going to keep us going. We'll use probably this type of format to try to keep you all abreast of what's going on internally, and we look forward to facing the challenges that are down the road for all of us.
Yes, thank you guys. I think that this concludes our meeting today. And just one last thought is be inventive when you run your clinic. Be inventive so that we become profitable and that we get back on track. So thank you again, and I'll see you guys when I see you.
Okay.
Thank you, everybody.
Bye-bye.
Thanks.
Bye-bye.